Hi, welcome to today's NephU podcast. I'm Tazin Aijaz with Otsuka Medical Affairs. I'm joined here today by Dr. Frederic Rahbari, who's the Director of Cystic Kidney Disease Clinic at Emory University and has been a practicing nephrologist at Emory University Hospital in Atlanta, Georgia since 2006. Today, we're going to be discussing the future of healthcare beyond 2020. Welcome, Dr. Rahbari. Thanks for joining us.
Thank you very much for inviting me to participate in this platform.
Yeah, thanks for joining us. So how has your practice changed over the past 6 months?
There are several aspects to that because I do hospital service coverage at the hospital. I have my dialysis clinic, and then I have my research projects, which are mostly clinical and investigational research. So starting with the clinics, and then the outpatient clinics. Starting with the outpatient clinics, I would say we very quickly switched to telemedicine and telehealth pretty much within the first 2 weeks of shelter-in-place order in Georgia. We already had the infrastructures for that. We had started telemedicine about 3 years ago at Emory. So all the infrastructures were on and we jumped on it, and really it didn't affect me that much. I basically saw all the patients through Zoom during that point. For about 2 months, we did not let anybody come to the medical facility. So all the clinic visits were basically telehealth visits. And the patients were actually very happy because they didn't have to drive a long drive to come to Emory. They didn't have to pay parking fees. And they were getting the expertise that they needed from us. So the clinic side was fairly smooth. We worked it out, and everybody was pretty much happy. The only thing that I missed was really that physical face-to-face part of the visits that I had with my patients before, particularly if I was seeing a new patient that I'd never seen. For sure, the face-to-face visit has additional value in those situations. For the return patients, it didn't matter that much. I had known them for many years, and it was working out pretty well. On the second aspect was my dialysis rounds. Dialysis rounds did not get affected. Again, because we had telehealth possibility, we were offered either to go to the clinics and round or use Zoom to do remote visits. I chose to see everybody face to face in the dialysis clinic because somebody at the dialysis clinic had to carry the iPad from patient to patient during my entire rounds, which is 20 patients. And that I thought that was a waste of time for our staff to just be there to pass on the iPad from one patient to the other. So I basically continued the same way. Many of my colleagues decided that they wanted to do all telehealth, and they did not go to the dialysis clinic. So that was the second part of my activity. The third part was really the hospital service and hospital coverage. Overall, when we look back, our overall activity as far as nephrology in our hospital did not change. Our volumes were pretty much steady. At the beginning of the pandemic, we actually had more COVID positive patients, and most of the hospital got shut down because all this elective surgeries were shut down. So I would say probably 40% of our hospital beds were not utilized during that point. But for us, it didn't matter. We had patients with AKI and COVID, which made up to everything else that we had lost as far as the volume that we had on the nephrology side. The last part was my clinical research projects, and that was fundamentally changed in the sense that all my clinical trials, the sponsors, and also our institution told us that we cannot enroll anybody new in the ongoing studies, and we could only follow up the patients that are already enrolled in the studies. Most of these studies are under FDA scrutiny, under IND. And so we had to really make sure that patients are remaining safe. We very quickly approved the methods of telemonitoring as far as patients going to a different lab close to their home rather than coming to the site, the clinical sites for enrollment in the clinical trial. So they did not come here. Most of the patients went to a lab outside. So we carried that for about almost 3 months until we got the approval to see patients face to face back at our site. Clearly, all my collaborators and investigators that I know, except for COVID-related projects, have suffered during this time because their projects have been on hold. They could not enroll anybody. During the meanwhile, my colleagues and I, we actually created several cohorts of COVID patients with acute renal failure or end-stage renal disease, and we're following that. We have more than 1,000 patients now in that.
Wow.
We're working on the publications. We've submitted 2 already, and there's 2 others that we're preparing for submission. So basically, we shifted from the typical clinical investigation that with clinical trials, randomized trials, to more of a cohort dedicated to COVID and try to figure out what the renal outcomes are and what are the determinants of renal outcomes in COVID positive patients, whether they're going to be ESRD patients on dialysis, transplant patients, or people who didn't have renal disease and they just had acute kidney injury.
Okay.
So that's in a nutshell what has changed for me.
Okay. Yeah, so it sounds like, there have been a lot of changes, in your clinic, dialysis, hospital, research, and obviously personally that you faced over the last 6 months. But, using a combination of in-person, virtual, you guys have kind of been able to get through some of these challenges. So how do you think, after we actually have, a vaccine, how do you think you're actually going to be seeing your patients? Do you think that you're still going to be using, virtual visits?
I think particularly for my clinic and for a lot of the subspecialty clinics in large academic centers, we actually learned that we don't really need to see the patients face to face, or the physical examination adds very little to our management, to change our management. The reason I'm saying this is because most of the patients that I'm seeing, the new patients, are always a second or third opinion on their relatively complex cases. 1 or 2 or 3 doctors have already examined the patient. So I have a physical exam by board certified doctors, board certified nephrologists before they come to me. And it's really a matter of getting the data together and making sense of the data, whether it's an imaging study, the lab, and then informing and educating the patients about their disease and coming up with the right diagnosis. So I think on that part, I feel that telehealth is going to stay, and it's going to probably expand in our practice because we're realizing that for a lot of patients, I have patients who come from Florida. So driving for them is 8-10 hours each way. Again, when I have everything on my end, I can share my screen with everybody, so I can share their images with them. I can share all the labs. I can make graphs out of their numbers and show them, so they're very appreciative of that. So I think this is going to stay with us. I think it's going to expand, actually. And there are some particular aspects that I foresee that we're going to see in the future that we haven't really even seen right now. We're going to have international telehealth with other countries.
Oh, wow. Mm-hmm.
The main issue is the payment system, but I have patients who come from other countries who see me. And I think, for them, it becomes a really major advantage. Even if they have to pay out of pocket for a visit, it would be cheaper than flying to Atlanta and flying back to their country. So I think telehealth, international telehealth from major academic centers that have very unique programs is going to take off. That's my prediction for the future. So far, a lot of the networks that have been set up are institutional networks that, you basically you have a certain foundation or clinic that has different sites, and they have different experts, and they basically all talk to each other to take care of a patient that's in a remote facility. Now we're going to move away from that model to a peer-to-peer network. So instead of saying, let's say, if we have my institution has 6 hospitals and I only go from one hospital to the other, taking care of patients at different hospitals, it would be basically I, as a physician, just go to including a different hospital and give advice to somebody who's in a different hospital. Obviously, that needs a lot of infrastructure set up as far as the legal frame of what you're doing. Again, the licensing, all those things. But I foresee that that's going to happen in the future. The virtual medical centers, the way that few healthcare systems have set up, they're entirely virtual. So there's no actually physical location for that. There's an entity, but there's no physical location. I think that will also come down the road. And the other thing that I really feel that actually would apply very much so to our dialysis clinics is our nutritionist work that can be completely, totally telehealth. So we won't need the nutritionist to be in the dialysis clinic. She or he can actually give recommendations to the patients over the phone. And also, so I think that's one part that would grow. One part that I think it's underutilized, we know that our ESRD patients, about 20 to 25% of them will develop depression or major anxiety during their lifespan of dialysis. And getting them to see a psychiatrist has been a very big challenge physically. And I think telehealth perfectly fits psychiatry.
Yeah.
The psychotherapy, psychiatry visits, all those things are the perfect setup for telehealth, that you don't need to touch the patient, you just need to connect with the patient. I think that's one thing that I hope that we can actually develop and expand. I know how hard it is to get my patients to go and see a psychiatrist or a psychologist. It's extremely challenging on dialysis.
Yeah.
You have their 3 days that they come to the clinic, they can't go anywhere else during the time. I think mental health visits with telehealth are really an easy shot, and they will take off. I think I foresee that mental health is going to be mostly telehealth from this point on. So I think these are the things that I was thinking about, how the practice is going to be changed
In the future. Yeah. I mean, it seems like, telehealth has always been searching for a place, and in this pandemic, it kind of finally found its place, and it'll just keep growing in the future, hopefully in a positive way. So obviously for the future, telehealth is really going to be one of the biggest forces. What do you think will be the main driver for the future of healthcare?
I think as far as telehealth, and as far as the healthcare systems, I know that our administrators are realizing that there are money-saving strategies through telehealth, and also patient satisfaction strategies that come with telehealth. And I think those two are going to drive the telehealth, because not only the system can save money, but it also can make patients more, happier with their care and more satisfied. So I think those two things are going to be the main drivers. There's a big part in the healthcare system which is managed care. So to name one of the biggest ones is like Kaiser Permanente, right? And in that situation, telehealth actually, so for my practice, we had to wait to get the green light from the payers to do telehealth medicine to get paid. Managed care did not have that problem from day one, because they're managed, they're part of a bundle, and there's a system that's providing everything for you at a very fixed cost. Their cost is contained, so they know what they're doing. So for them, and from the numbers that I saw, about 60 or 70 million people are in managed care now in the United States. So that's out of
Mhm.
300 million people. It's a good 25% of our entire population plus that is actually under managed care. For managed care, I foresee a major drive for telehealth because they are in a cost-contained structure and
Mhm.
they don't have to pay with payers. They are the payer and they are the insurer. So I think that again, I would say that the money saving strategies and patient satisfaction are going to be the main drivers of the future of the healthcare in parallel. And telehealth would actually meet both goals, in a lot of cases.
Mhm. So how do you actually measure, the patient satisfaction portion that patients are satisfied with telehealth?
But we haven't done a survey yet, but it's not hard at all. I hear it with every single patient that comes on Zoom. At the end of the visit, they all tell me, this was really easy, this was great. I actually spent more time face to face with you because there was no nursing, rooming in, rooming out, checking in, checking out, all those things. So they actually spend, if I have a 30-minute slot with them, they're spending 29 minutes with me, literally.
Mhm.
So they're very happy about that. All of them, all of my patients literally say that at the end. A lot of them mention that not having to drive to the site is a big plus, especially
Mhm.
the traffic that we have in Atlanta. And
Yeah.
also a lot of them tell me, oh, I didn't have to pay parking this time, which is, if you think about it, it's only $5 or $6, but that really matters to people. I mean, for
Yeah.
some, the psychological burden of the parking ticket, it seems to matter a lot to the patients.
Yeah, no, I get it. My husband hates paying for parking, so I can relate to that. I mean, so it seems like, even though this pandemic has brought a lot of challenges for all of us personally and professionally, a lot of positives have also come from it. We've found a place for telehealth. It has this patient satisfaction, cost saving potential. But what is really your biggest concern for the future of healthcare?
A lot of the healthcare systems basically decided that a new patient should be physically examined, so they're limiting their telehealth visits to follow-ups. But in my practice, again, because of the nature of my second and third opinion, visit in my patients, it doesn't matter that much. So that's the telehealth part, the concerns that I may have. As far as in general, the concerns for the future of the healthcare, there are two major issues with our healthcare system in the United States. One is a personal issue, one is a healthcare system issue. The healthcare system issue is that our cost is constantly increasing and exponentially, completely disproportionate to inflation. So that cost increase is affecting your insurance premiums. And that's why I'm hearing more and more of my patients are actually moving to high deductible uh, plans that are only basically worth in catastrophic situations when you have a huge hospital
Mhm.
bill. And I think that increasing cost, which is related to several things, more access to healthcare, more expensive and more accurate innovations and treatments, all of those have a cost, and it basically reflects on your premium in insurance, your out-of-pocket costs, and all those things. So I think that's a main issue that our system has to at some point face. And I'm talking to some of my physician friends that basically they moved to high deductible plans, which was unheard of, 15 years ago. No physician would have got a high deductible plan. Everybody wanted the Rolls Royce, insurance policy to be covered and not have to pay a lot out of pocket. So that's one thing that I see as a system, as a healthcare system issue for United States. The second one is I see a lot of physician burnout, and that is a major issue for me, as far as looking around me and seeing, do I see happy physicians or do I see physicians that are tired And if you ask all the physicians, they would tell you that what makes them tired at the end of the day is not the patients, it's really the documentation. The amount of time that they're spending on documentation, on challenging decisions made by payers, and going back to the payers and appealing a decision and this and that. Prior authorizations takes time, from the offices. All those things that are more in lines of documentation and paperwork of healthcare that have a huge implication on the survival of physicians are actually burning out the physicians. And there are
Mhm.
several surveys that have clearly pointed out that. So I think those are the two things that I see as concerns for the future of healthcare. The one on the physician side, one on the healthcare systems, and what basically comes down to the patients because of that.
Yeah, and I've honestly, I've heard a lot more people talking about specifically the burnout of not just physicians, but nurses, physicians, other
Absolutely.
healthcare professionals. What are solutions for that? I mean, because the documentation, it can be
I think
intense.
there are some things that have naturally happened without anybody really pointing towards that, but I see that. For instance, when I was in training, if you wanted to be an internist working in a hospital, you had to work pretty much, 5 days a week, the regular full time and more than full time. Nowadays, the hospital medicine system works in a way that you work 1 week on, 1 week off, and that kind of gives a little bit of personal time to the providers. But for nurses, it's been a long time, that they typically can work 40 hours, which is 3 shifts or 3.5 shifts a week, and that's it. They can take the rest of the time off and enjoy their lives, their personal time, with their families, and that definitely has a major impact on their satisfaction and the burnout rate. I think, for instance, all these hospital-based jobs that are either in lines of critical care, hospital medicine. Now, there are hospital systems that have in-house, hospitalists in nephrology or other cardiology or other fields. All these things are actually really gearing towards that burnout point. They're going after that, and they're trying to address that to basically give more time off to the providers, to reduce the burnout. I think that's one thing that has happened, regardless of whatever we have on the background of paperwork and documentation that we have to do. I think what could change the game is really the next step of if we get to a not necessarily a single payer mode, but a system that does not link your documentation to your payment. Right now, the main reason that our documentation has to be extremely extensive and detailed is actually the payment. People think that lawsuits are the cause of that. It's actually not. Lawsuits happen in less than 1 in 1,000 or 1 in 2,000 patients that you're going to see. The billing is every single patient that you see. So the billing is there no matter what. And the
Mhm.
main thing that we have to document so much is actually the billing part. And if we get to a point that we dissociate that payment system with the level of documentation, then the provider satisfaction is going to increase. I don't see that happening under our current system. I don't see even a move towards that, because again, everybody's locked in the payment system right now, and everybody's just following the rules. I don't even see that in contained cost healthcare systems. Even they have to do the proper, very extensive documentation. I can testify on that because I practice in France, and that's the socialized healthcare system before coming to the US. And over there, our level of documentation is 1/10 of what we're doing here. And
Wow.
that causes provider satisfaction, because you really take care of the patient instead of spending your time on computer and putting everything down in a note. That time is the face-to-face time that you're spending, and you're paying attention to the patient. So So I think, that's one thing that I wish I had a fix for it, but I don't see an immediate fix for that.
Yeah. Yeah, I mean, it's definitely, I think, a challenge because we have to realize that it's not just this healthcare system where we've kind of found so many cracks in it that a lot of us have known for a while, but this pandemic has really, really shown us, all of these kind of holes in our healthcare system. But what a lot of people don't realize is like the people that are actually providing care, if we don't care for them and make sure that the system is working for them, what's going to happen to the patients. So it's definitely glad you provided that very valuable insight. And as a NephU community, we're constantly trying to figure out what kind of education can we provide to people, to people on our platform, to the NephU community. So how has NephU potentially helped during this time of uncertainty?
I think to just share our point of view as far as what the pandemic has done to our infrastructures, the way that we're providing care, what is the pros and cons. That's a major topic and a value. So education that these kind of platforms have put out definitely has helped. We have continued through these platforms to educate doctors about specific diseases. I participate in disease education, for polycystic kidney disease, and the pandemic has not put a halt to our effort to do that. So, and platforms such as yours are basically what we're using to continue doing the job that we used to do on a face-to-face basis through virtual platforms. So I think no matter what, during these times, patients still need care, and the information has to be carried to the physicians to do a better job of taking care of the patients. So all of that will get help from platforms like NephU, and that's how I feel about these types of infrastructures, how they can help to achieve those goals.
And Dr. Rahbari, we always appreciate everything that you do for NephU and all of the education that you've helped us build. So we really do appreciate that. And what more can we do? How can we continue to improve awareness, for polycystic kidney disease and for others?
I think, particularly for polycystic kidney disease, our big challenge has been that for many, many, many decades, not just years, this disease was, basically a kiss of death. If you get diagnosed with it, I can't do anything for you, and you come back when your kidneys fail, I'll put you on dialysis. I've heard that story hundreds of times if it's not from my direct patients, from their parents, from their uncles, aunts, grandparents, that they went to the doctor and that's what they were hearing. Now with more and more education about PKD and saying that, listen, this disease is not a kiss of death. This is something that we can work on. We can potentially prolong the kidney life of these patients by 10 years by doing all the things that we have available right now in our hands, to take care of these patients. And 10 years or 15 years off dialysis is not a cheap change. And for patients, even 5 years, even 3 years of not going on dialysis is a huge difference in their quality of life. And I'm not even talking about the costs that's associated with that. I'm just talking about the patient experience. So I think, platforms like this, we need to really take it down to informing, educating, and educating more and more physicians to know about this disease and all the other diseases that NephU can put under its belt, not just polycystic kidney disease, and inform and educate providers about that and patients. I think the main thing that's going to change the outcomes is really breaking those old mottos that polycystic kidney disease is incurable and we can't do anything about it. You're going to go on dialysis, which is really a very wrong approach to take that disease on. I think that's how I see that I still feel that education is really the way to go, and we have to expand it to more and more providers and also patients. And that's how we're going to change the game,
Yeah,
particularly for rare diseases.
you're absolutely right. I think that's what we've learned, with while we've started NephU, like just having a platform and educating people, we're learning how many people don't actually know
Yep.
about some of these disease states. So really appreciate your insight. So thank you so much for joining us today to discuss, the future of healthcare. We really appreciate your time. And to the NephU community, thanks for tuning in. We'll see you next time. Bye-bye.
Bye. Thank you.